Right. Good evening, everyone, and welcome to the first LEJEndo in 2025. We were just discussing that this is the third year that we've been doing LEJEndo for. We've now run 22 sessions, and we have had quite a lot of interest and a lot of views on the channels that the videos are uploaded to. So welcome to our first session in 2025. I would like to thank the whole team, really, and the team has changed over the years to some extent, mostly in their progress. So now we have Mikey as my consultant colleague on the panel, and Ben has become a consultant in Guildford as well, and hopefully the others will soon step up as well. So the team you all know, Flo Britton now is in charge of organizing the LEJEndos. Kyle has been helping out quite a lot, and particularly he's the one who has done a lot of work in selecting the papers. We have Mega, who's presenting today for the first time. Avril Bachi is in fact the star of the show tonight, so he's the featured presenter. But Avril, of course, last year was running the show as well. And Mikey, who you all know, and Ben as well, the whole of the CMIG London team are here. So tonight's talk is, I promise there's been no special treatment here, because as you will notice, this is actually our paper. This is a paper that has been published a couple of months ago by the CMIG team, and this is the outcome of 1,116 procedures that I have ever done over the last 8 years using the SoSure approach. So Avril's going to talk you through this. This is a paper that the whole team has done a lot of work to get to this stage, and for obvious reasons, it's very close to my heart. So let's go straight in and start with a couple of small papers that we're going to present, and then we'll have time to discuss and go for question and answers as well. So I think Kyle is going first, or is that Mega?
No, it's me. Yeah.
Okay.
So this is relatively hot off the press in fertility and sterility, and it's published by a group from the Netherlands, and I'm sure we will recognize a few of the names here. And this study focused on recurrence following surgical treatment for endometrioma, with a focus on rates in those who did not receive hormonal treatment. And the purpose of this study was to act as a background in preparation for another upcoming trial called the SOMA trial, which is an RCT and a prospective cohort study comparing surgical versus medical management of endometrioma. So just discussing the key points, this was a study that synthesized data from 55 studies in total to investigate recurrence rates of ovarian endometriomas following surgery, and as we've said, specifically in those who did not receive post-operative hormonal treatment. Of these 55 studies, 23 were included in the meta-analysis, which included 1,204 participants, so a real decent sample size. We know that despite comprehensive surgical treatment, recurrence of endometrioma is relatively high, and we know that hormonal treatment can improve rates of recurrence, but is not suitable for all patients. So in this study, they found that recurrence rates increased progressively over time after surgery, which I guess is to be expected. And due to sample size as well as diligence from the authors, the evidence appears to be robust. However, this study's limitations do include high variability among the studies and a lack of standardized definition for recurrence. which could influence the interpretation of results. That being said, like I've mentioned, the authors made every effort to make up for limitations, even including contacting original study publishers and authors for raw data where possible. Here's an overview of the various surgical methods, with cystectomy being the most common, and other methods were derived from studies that looked to limit to reduction to ovarian reserve or where cystectomy was not possible. Drainage studies were not included, which of course makes sense, but if this was a secondary technique, and by that I mean if they aim to do a cystectomy and or coagulation and or vaporization treatment, and they were not able to do this fully or partially, then they aim to include these results also. This was a very small number of participants in total of that 1,204. Here's a breakdown on recurrence definition. The use of imaging to define recurrence was widespread, which ensured reliability overall, but there was a lack of standardization. The absence of a universally accepted definition for recurrence highlights the need for maybe an international consensus to complete.
Oh, I think we lost Guy. Okay, while we wait for Kyle, do you want to show the result of the poll, if everybody has voted?
And to summarize, this meta-analysis demonstrated a steady increase in recurrence rates over time, peaking at 27% by 24 months post-surgery.
Okay, so we lost you for a few seconds, Kyle, but I think
Oh, sorry, I'm back now, yeah.
No, we got the gist of it.
Yeah.
So the poll's interesting. 50% are not actually far off. Although I noticed that we don't have a 10 to 15%. I think Flo didn't put that on purpose because she knew what the right answer was. But I think we count the ones that said 20 to 30 as right answers. I actually would have thought it's more than that. It's interesting, 15%. So we now can quote that. The only thing I would want to add is we have to always remember the bias that the studies that get published are usually done by expert surgeons who you can assume that they are showing their results because they are good results. I mean, I can't be sure of that, and you would hope that you live in a world that every data is published, and hopefully one day we'll get there. But normally there is a publication bias there. But yeah, maybe 15%, just over 15% is not a bad number to quote. Is that your experience, Mike? Is that what you think recurrence rate should be? Okay, I don't think Mike can hear me.
Sorry, Shaheen, my internet is breaking up as well. Say it again.
Yeah, is that in line with your experience with recurrence of endometriomas?
I think it is. The interesting thing is that also that we don't know whether if we operate on someone, we don't have a very good follow-up system for a lot of those patients as well. And it's impossible to say if they're gonna go somewhere else.
Yeah, sometimes no news is good news. A lot of these patients may have had recurrence, but we don't hear. Okay, perfect. So Megha, you're on.
Yeah. So I'm presenting a paper that was published in the Journal of Assisted Reproduction and Genetics. Essentially, this paper provided a comprehensive summary, a comparative summary of the effects of thermal versus non-thermal hemostatic methods on the ovarian reserve after a laparoscopic ovarian cystectomy. And the ovarian reserve was measured in terms of two variables, that is AMH and antral follicular count, or AFC. The peculiar or the important aspect of this paper is that it also provided a subgroup analysis for endometriomas and other benign ovarian cysts. Next slide. So for the paper, they went through data which was selected studies from Cochrane Library, PubMed, Embase, and Web of Sciences databases. And studies that met all of these inclusion criteria were selected for the analysis. So all the studies had to be randomized controlled trials. All the studies were looking at diagnoses of endometrioma or other benign ovarian cysts, and they underwent laparoscopic ovarian cystectomy. The studies should also have looked at the effects of, or compared the effects of thermal versus non-thermal hemostatic methods on the ovarian reserve and the impact on ovarian reserve. And there should have been a pre-op and a post-operative AMH level or antral follicular count. Conversely, studies which were not randomized control trials or which were expert opinions, reviews, or case reports were excluded. And studies which did not evaluate the ovarian function or did not specify the hemostatic method were also excluded. And studies which looked at solid tumors, for example, lymphomas, fibromas, or malignant masses were also excluded. Next slide, please. So a total of 13 randomized control trials were included, out of which 8 exclusively looked at endometriomas and the effect on endometriomas, whereas 5 randomized control trials looked at different benign ovarian cysts, including endometriomas. This led to a total of 1,043 patients being analyzed, who were in the age group of 18 to 45 years, and they underwent a laparoscopic ovarian cystectomy for cysts ranging from 3 to 10 centimeters in diameter, and the basal serum AMH levels were comparative between the two groups. The bipolar current was in the range of 20 to 40 watts, and the non-thermal hemostatic methods that were included were suturing, which was looked at 6 studies, and 6 studies considered hemostatic matrix or sealants. And there was one study which looked at combined hemostatic matrix and suturing as the non-thermal hemostatic method. The mean serum AMH levels were then measured at 1 month, 3 months, 6 months, and 12 months post-operatively to evaluate the ovarian reserve. Coming to the results, the post-operative serum AMH levels of patients with endometriomas in the electrocoagulation group were significantly lower than the ones in which non-thermal hemostatic methods were used during the laparoscopic cystectomy. In these charts, we can clearly see that when it comes to benign ovarian cysts, it crosses the line of null effect. So there is no difference whether you use a non-thermal method or electrocoagulation for achieving hemostasis. Whereas in the endometrioma group, you can clearly see a decline in the AMH, whether it is at 1 month, 3 months, 6 months, or 12 months. So it clearly favors the use of a non-thermal hemostatic method for achieving hemostasis. Next slide, please. We see a similar pattern when we analyze antral follicular count, and wherein you can see for benign ovarian cysts, there is no significant difference whether electrocoagulation was used or a non-thermal method was used, whereas there was a clear decline in antral follicular count when electrocoagulation was used as the primary method of achieving hemostasis in the case of endometriomas. So to conclude, there was a significant difference in the post-operative AMH and antral follicular count in patients with endometriomas between the two groups, thereby favoring non-thermal hemostatic methods over electrocoagulation for preserving ovarian reserve in patients with endometriomas. Now, because endometriomas also inherently have adverse effects on the ovarian reserve, with the significant detrimental effects of electrocoagulation during surgery, the use of electrocoagulation should be avoided in these women. However, because it is not very different for other benign ovarian cysts, it is a viable option to achieve hemostasis, as I said, in benign ovarian cysts and also in patients with endometrioma who are not so much desirous of future fertility. However, ultimately, it demands a tailored treatment based on individual needs and the clinical considerations.
Thank you very much. So, Megha, did I understand correctly that basically they're saying for non-endometrioma cysts, it doesn't matter if you use electrocoagulation, it's the same. Okay.
Yeah, so yeah, that's what they're trying to say. And even for the benign ovarian cysts, for all the times that it has tried to favor not using the non-thermal methods, it is because most of these analyses, the benign ovarian cysts also included endometriomas. So if endometriomas are strictly kept different. Yeah.
What do you think the rationale is? Because look, we all understand that excision of endometriomas reduces ovarian reserve. Okay, so we don't have any argument with that. But why would using diathermy in a non-endometrioma be less detrimental than using diathermy in endometrioma? I don't know, Ben, do you have any?
But I think like the point is like if you have a simple cyst, like even if it's 10 centimeters, it doesn't really bleed much. So the amount of bipolar that you use is really in one or two spots. In an endometrioma, if 4 centimeters endometrioma potentially has so many bleeding areas. So I think this is
But that, yeah, I think you're right. I think that's probably the explanation. But then it's really not, that's my problem with surgical studies, that we're not really comparing like for like.
Yes, exactly.
So we're
This
not
is the
comparing the same amount of diathermy. You know, that one is probably one buzz of diathermy, the other one is cooking the whole of the inside of the ovary.
Yeah, exactly. It depends who does it as well.
But
I was just going to add the paper also gave that as a possible explanation, Mr. Kazali, that for endometriomas, because there may be an element of pelvic adhesions as well. So the compromise, and they bleed when you strip off the cyst wall, because of the altered vascularity, the bleeding tends to be more than other benign ovarian cysts. So in trying to sort of perform a full adhesiolysis and the altered vasculature of the cyst wall itself, in the way it's sort of feeding off the ovarian cyst, there could be more bleeding, and then you could end up possibly using more endoelectrocautery than what you may use in other benign ovarian cysts.
okay.
That was one of the postulated explanations.
So, hi, there is a question for you from Marco. Do you want to take that? Regarding endometrioma treatment, what kind of ablation, in your experience, works better? You're on mute.
So I'll answer kind of what I think, but also what if you're asking about the study, Marco, they didn't really, they said about this number of studies that use different techniques, and vaporization would potentially be referring to depending on what it was, helica or another type of kind of plasma type beam. I know there's lots of different ones available, and then electrocoagulation again, and ablation, lots of different things. There was only a few studies that used alcohol sclerotherapy. I think what I have found from the reading I've tried to do and what I have seen is that you got to have obviously lots of tools in your shed, but you do the thing that works the best. I know that makes no sense, but beforehand, you need to have that discussion with the patient, and you need to say, I believe cystectomy has the lowest rate of recurrence, but the highest effect on your ovarian reserve. I can do these other treatments, and I need to accept as a surgeon that I may start a cystectomy, and then actually when I find I'm digging a hole in the ovary, I need to be able to change tack and accept that I might not be able to do a complete cystectomy. I might have to do a partial cystectomy and an ablation. So in terms of these different techniques, there was very promising early data about alcohol sclerotherapy, but now probably has a similar rate of recurrence and or similar rate on AMH. And then again, you can probably go deeper with these different therapies. For example, plasma jet. I may one day be very good and only just ablate the superficial surface, but I may end up going too deep. So it really varies from time to time. So depends what you're doing and in whose hands, I believe.
All right, yeah, that's a good answer. I think I agree with that. And ultimately, I think it's going back to the surgical principles of endometriosis, that you have to put the patient in the center, and there will be lots of different factors that you need to consider. For some patients where future fertility is of less importance, then you will do everything you can to excise, understanding that you are reducing the ovarian reserve, but you remove all the endometriosis you can, like you do for the rest of the pelvis, or I hope everybody does in the audience, that we aim to excise all of the endometriosis that we find in the pelvis, ovaries included. But we always need to balance that against the patient's wishes, the effect that this will have on the ovarian reserve and all the rest of it, and then use the appropriate method. Now, okay, so I think it would be only appropriate if I give a little bit of background about the study that Avril is about to present. I think this has been in the making for, guys, you tell me, Ben, it started even before your time, I think.
Yeah, I think it started before my time.
Yes, it started before your time, but you were quite crucial in getting the database up and running, and setting up the whole scene. And we had this huge Excel database, and then Kyle did quite a lot, and Avril did quite a lot. Mikey has helped with data collection, and the whole team has helped. But I think it was published mostly, it was during your time, wasn't it? Well, accepted during your time, because you were the one who actually wrote the paper and sorted out the database. So this has taken a long time, but this is one of very few single surgeon large volume studies that has been published. There are some bigger studies that have been published from meta-analysis and centers with multiple surgeons, but I'm not sure if there are many cases, many papers. I think 2 or 3 maybe. So I'm very proud of it, and Avril's going to tell us what we found.
All right. Are you guys able to see my screen?
Yes?
Yes.
Okay. Right. Hi, good evening, everybody. Thank you for joining us in our journal club today. So today I've got the great pleasure of presenting this study, which I did during my fellowship with Mr. Shaheen Kazali, which was just about 2 years ago. And the reason why we did this study was to evaluate the rate of intraoperative and postoperative complications by a single surgeon who has adhered to the same structured surgical approach consistently, and to also demonstrate the learning curve of a surgeon over the course of the 8 years. So next slide, moving on to our methodology. So this is a retrospective study. We looked at all the patients that were operated, who underwent surgery for endometriosis by Mr. Shaheen Kazali between January 2015 to 2023, over the period of 8 years. And we excluded patients who had excision of endometriosis without any concurrent pelvic disease. So for example, these were the patients that had excision of rectus sheath endometriosis without having a laparoscopy, or umbilical endometriosis alone. We also excluded patients who were lacking essential medical documentation that prevented us from collecting our notes, our data accurately. For this study, we also used the nomenclature that was derived from the consensus of the International Working Group of AAGL, ESGE, ESHRE, and the World Endometriosis Society. And we also incorporated the 4 different endometriosis classification system, which is the revised ASRM, AAGL, #NZIAN, and the Venus classification system. So this is a short slide on what I meant by the structured surgical approach which the author adhered to. I'm sure some of you must have heard of the social mnemonic, which is a mnemonic of the surgical steps that we use to tackle endometriosis surgery, with S being survey and sigmoid mobilization, O for ovarian mobilization, S for suspension of uterus and ovaries, U urethrolysis, R rectovaginal and pararectal space entry, and E excision of all visible endometriosis disease. When I say structured approach, it doesn't mean that we just adhere to this in a rigid step. However, this provides a framework every time we tackle endometriosis surgery. And in terms of the surgical procedures that we perform, we define shaving as the excision of bowel serosal and subserosal endometriosis. In terms of discoid excision, we divided it into 2 different types. There's partial thickness discoid excision and full thickness discoid excision. So partial thickness discoid excision was reserved for disease that infiltrated the superficial muscularis layer only of the bowel. And following the excision, the defect required some reinforcement sutures. Whereas full thickness discoid excision was for nodules that were full thickness, however, measuring less than 3 centimeters, and removal of this nodule required opening of the anterior wall of the rectum, excising the disease and repairing this defect, either by hand suturing with resorbable stitches or using a transanal circular stapler. And for segmental bowel resections, this is usually reserved for larger nodules exceeding 3 centimeters in size or where there is multifocal disease. In terms of cases where we had to open both the bowel and the vagina, we perform an omentoplasty to reduce the risk of rectovaginal fistula. So now moving on to data collection. So we have 2 different types of databases. The first one is our UK national database, which is the BSGE database. And this captures patients with rectovaginal endometriosis in which the excisions required the pararectal spaces to be entered. And this database captures patients' pain symptoms, quality of lives, the surgical details, and some of the major intraoperative and postoperative complications. Our patients had to fill pain and quality of life questionnaires at 6 months, 12 months, and 24 months postoperative. We also have our own local database, and for this, we included all of the patients who underwent surgery for endometriosis, including the patients who had only superficial excision of the disease. And our database captured more comprehensive surgical findings, intraoperative and postoperative complications. And in 2022, during Ben Mondelli's fellowship year, we updated this database to include the 4 endometriosis classification system. So in order to update this database, as clinical fellows, we went through the hospital electronic records of all our patients retrospectively. We assessed their notes looking at their operation notes, surgical images, follow-up clinic letters, discharge summaries to get all the information that we needed for our data collection. For patients that were missing some of these information, where we were not able to find their notes, we excluded them from our study. And after getting all this information, myself and Mr. Kazali then went through the patients who had intraoperative and postoperative complications and went through their notes once a time again to ensure that there was factual accuracy. This slide is a short slide on what a Venus scoring system is. This is an endometriosis scoring system that was devised by Shaheen Kazali. And a paper on this, I understand, has been published last year. And my colleague Kyle Fleischer will be presenting on this paper in March in our LEJEndo session. So essentially, for Venus, we divide the pelvis into 9 different compartments anatomically, and we score them from 0 to 4, with 0 being no endometriosis, 4 being very deep endometriosis invading into the structures. For example, your full thickness vaginal nodule, bladder nodule, or bowel nodule. 1 is for superficial endometriosis, 2 is for deep endometriosis without any adhesions or filmy adhesions to the surrounding structure, whereas 3 is for deep endometriosis with dense adhesions to the surrounding structure. In terms of our data collection, we use simple Microsoft Office tools, which is namely Microsoft Excel, to collect all our data. We also used it, as you can see below, to create a dashboard, which gives us live feed on our data at any point in time. And with the information from the Excel spreadsheet, it can be then used to then transfer onto a Microsoft Word to create our operation notes. At present, Mr. Ghazali has also created a new platform for recording surgical data and creating operation notes known as MARS, which you will be, Mr. Ghazali, correct me if I'm wrong, you'll be speaking about it at the end of the presentation, or do you want to speak about it?
I'll show everyone what that is, yeah.
Okay, I will stop sharing and then you can, yeah.
Oh, do you want me to do it now? Okay.
Wait, did you say you want to do it now?
You carry on, I'll do it.
I carry on.
Yeah.
Oh, apologies. Okay, yes. And Mr. Ghazali will go through what MARS is about. Essentially, it uses artificial intelligence to record all of their data, and I've used it myself, and honestly, it has really reduced my working hours significantly. Okay, moving on. So in terms of complications, so for intraoperative complications, we use the class intra classification system. So in this classification system, there's 6 different grades, with 0 being no complication, 5 being a complication resulting in death. Grade 1 would be any deviation from the operative course without the need of additional treatment. Grade 2 would be deviation from the course with additional minor treatments, such as if there was bleeding inside, you needed to give the patient tranexamic acid. If there was a serosal injury to the bowel, it just required reinforcement sutures. Grade 3 was anything that required moderate treatment or intervention. So if there was a bowel injury, you needed to do a segmental resection. For the bleeding, you needed to ligate an artery or give further blood transfusion. And grade 4 was anything that required major or urgent treatment or intervention. So life-threatening bleeding, massive hemorrhage requiring ICU stay. Okay, moving on to the results. So over the course of 8 years, we had 1,047 women who underwent 1,116 procedures, mainly in the private sector, and half of it was in the public sector. We excluded 20 patients from the analysis. 2 of them did not have any concurrent pelvic endometriosis. 18 had incomplete or missing crucial hospital notes. To avoid biases in our study, we also looked at whether these 18 patients had any complications that would then skew our data, and none of them had any recorded any complication. So this is our table of the number of procedures that were recorded each year, the number of bowel procedures that was recorded each year. And you can see there was an increasing trend in the surgical volume each year. It reached a peak in 2019. Understandably, in 2020 and 2021, the amount of surgery reduced significantly because of the COVID-19 pandemic. Surgery in the NHS was not happening. Surgery in the private sector was also being scaled down. And then after that, the surgical volume slowly started to pick up. You can see as well, the number of bowel resections also showed an increase as well, and the number of shaves and the rest as well. In terms of the proportion of the complexity of the case that was done by the author, as you can see, the one in orange is AAGL stage 4. It shows a general rise in the trend. This is similar with ASRM stage 4 in the dark blue. We also looked in terms of how we classify severity of disease or complexity of cases with venous. And what we did was we looked at the cases which had venous stage 4 in at least one compartment. So there was at least either a bladder nodule, a bowel nodule, or full thickness vaginal nodule. This also showed a steady increase. And venous, we also looked at cases which had venous stage 3 in at least 3 compartments where there was dense adhesions between the organs because of endometriosis. This in the light blue again showed an increasing trend. So next slide. I'm not sure if you guys can see this table. So this was a table in our paper which described our intraoperative findings. So I'll start off first with the root of the procedure. 99.4% of these procedures was performed laparoscopically or robotic assisted. There was only 59 cases, which is 5% of robotic assisted laparoscopy. This robotic assisted surgery was introduced in the author's practice in March in 2022. And from what I understand now, Ms. Ghazali, you are doing more cases of no more robotic assisted cases versus laparoscopic. We had one open case. This was a case of a patient wishing to preserve fertility who had an 18-week size uterus, and the author did an open myomectomy because at that time, and this happened in the early part of his career, and he felt that suturing the defect of the myomectomy open was a better closure than laparoscopically. We had 5 cases of laparoscopy converted to open. So one was because of an enterotomy, and the colorectal surgeons felt that they would achieve a better closure by performing this open. The second one was in a case of a segmental bowel resection, and they had to convert to open because of a malfunction stapler. 3 of the cases that were converted to open were planned conversions to open, and this was joint procedures with the urology team where there was a planned urological procedure such as reimplantation. And this is because at that time, the urology team were not performing these cases as laparoscopically. So the author would be excising the endometriosis laparoscopically and then handing over to the urology team to perform the urological procedure as an open procedure. So we still included that as our laparoscopy converted to open. If you look at our NZIAN classification, so in terms of our NZIAN A3, more than 1/3 of them had A3 in it, so 37.3%. And C3, that means a rectal nodule more than 3 centimeters in size, 31.1% of patients had this. In terms of bowel procedures that was performed, out of all our endometriosis cases, 571 bowel procedures were performed, which accounted for 51.2% of the 51.2% of all procedures. Right, so this slide looks at our ileostomy rate. So during the whole study period, we had 7 cases of primary ileostomy, giving it a rate of 0.6%, and in a rate of 1.2% of all bowel procedures and 10% of segmental bowel resection. What was interesting to know was, in terms of primary ileostomy, all 7 were performed in the first 4 years of the study period, so between 2015 to 2018. And between 2019 to 2022, no ileostomies were performed. And this represents the increasing confidence and the learning curve of the primary surgeon and the colorectal surgeon. However, what was important to know was that in the first 4 years, we did not record any emergency cases that needed ileostomy. However, we did record 4 cases that required ileostomy, 2 in needing ileostomy for bowel leaks and 2 needing for a fistula. So I also then looked at the literature and how did our ileostomy rate compare with other authors. So Braun et al. Reported a use of primary stoma in 44% of his patients are undergoing segmental bowel resection. In a study by Abo et al. In 2018, in 364 patients, almost half had a stoma for segmental resection. 55% had a stoma for a stoma in discoid excision. A study recently done by Ceccaroni et al. And his team, this which was published in JMIC, showed that in 3,050 patients undergoing bowel resections, 27.4% required had a primary stoma. And Professor Malzoni also did his study. This was also a single surgeon study. 248 patients, 1.6% had a stoma. I think that accounted to like 2 patients or something, two to 3 patients from memory. And the patients who required these were those with very low staple lines and also had opening of the vagina. Okay, this slide is looking at the complication rate. So the image on the right side over here looks at our intraoperative and major postoperative complication rate throughout the study period. So the one in blue is the intraoperative complication rate, which if you look from 2015 to 2022, does show a general decline. The major postoperative complication rate remains stable throughout the whole study period. We know that the proportion of complex cases, namely stage 4 endometriosis cases that were performed throughout the study period, was increasing. However, the rate of complications which remained stable during the whole study period, and which is likely due to the progressive increase in the surgical skills being offset by the rise in complications. In terms of our intraoperative complications, all of them were class intra type 2, grade 2, which means did not just required a minor intervention, such as a suture. And in terms of bladder injury, we had 3 patients, all repaired by suturing of the bladder. Ureteric injury, all 4 were repaired with ureteric stenting, and none of them had any postoperative sequela. This is looking at our major postoperative complications. So I didn't cover the minor part, but the rate of minor postoperative complication, grade 1 and grade 2 clavendingo, was 13%. In terms of grade 3, it was 1.5%. We did not record any stage 4 or grade 5 complication. And as I mentioned, 5% of the procedure was performed robotically, and no cases of major complications were recorded in the robotic case. However, the numbers are very small compared to the laparoscopic ones. So we had 17 grade 3 complications. 2 was grade 3, 2 was grade 3A, 15 was grade 3B. So then when we looked at our rate in bowel procedures, it would be 0.4 in bowel procedures for grade A, 3.3 for segmental resections, 1.8 in grade 3B for all bowel procedures, and 3.3 in segmental bowel resections. We had 2 cases of a bowel leak. So one was from a shave. This lady actually returned to hospital with a pelvic abscess. She had the surgical drainage of the pelvic abscess. She returned a few days later, feeling unwell, and then was diagnosed with a leak. The second one was someone who had a segmental resection and came back with a leak as well. We had 2 cases of rectovaginal fistula. One was a shave together with a hysterectomy, and one was a segmental resection with a partial vaginectomy. I actually assisted in the second case, and from memory, this lady had a very large and low nodule as well. And we did counsel her about having a stoma before having a primary stoma. However, this her partner had a history of bowel cancer, and he had a stoma as well, and she really wanted to avoid that. So on further counseling, the patient herself accepted this risk of rectovaginal fistula and did not want to have a primary stoma placed in the first instance.
Gabriel, if you were assisting, it must have been your fault.
I think my camera action was not ideal, probably. And then just almost finished. Yep, last two slides. So how do we compare with other studies? So Abo et al. Looked at their rate of clavin. So our rate of clavin dindo grade 3 in all bowel surgery was 2.1. Segmental was 6.7. And in terms of grade 3B, so major 1.8 and 3.3. So 2.1, 6.7.
Just to remind everyone, return to theater is 3B. So if the patient had to go back to theater, that's 3B. 3.3% of our segmental resections had to go back to theater.
Yep, one was for a fistula and one was for a stricture. Okay, so we looked at other studies and we wanted to see how our study compared to other studies. So Abo et al. Showed that the rate of clavin dindo grade 3 complications in all bowel surgery was 11.8. This further increased to 20.9 in the segmental resection arm. There was a systematic review done by Sofian Bendifala and his team, which showed an overall complication rate for endometriosis and bowel surgery between 2.2 to 9.9, shaving being 2.2, disc being 9.7, and segmental being 9.9. Professor Malzoni published his data in JMIC in 2016, involving 248 segmental bowel resection, and his rate of fistula was 2.4%. And as I mentioned just now, all cases of fistula occurred in those with very low staple lines and with a concomitant vaginal suture with no protective ileostomy. And lastly, Professor Ceccaroni's study, which was published in JMIC last year, in 3,050 patients who underwent segmental resection, the rate of fistula was 1.9%. We also then looked at Professor Hudali's study, which looked at the volume of surgical activity and how it correlated to complication rates. What he found was surgeons that were doing less than 40 cases over 2 years was low volume, then moderate volume was 40 to 69, and high volume was over 60 cases over 2 years. And he did find that the rate of complication did reduce as the volume of centers increased. So like in terms of leak from 4.4% to 1%, fistula 2% to 0.42%. And this table was to highlight that we fell under the category of over 60 cases over 2 years, which could be an explanation for our low complication rate. So this is the conclusion of our study. It represents the data of a single surgeon, which reflects consistency in the philosophy of care. It limits the heterogeneity in surgical practice and decision-making protocol. This study also showed a low rate of intraoperative complications and major post-operative complication. And we believe that adherence to a standardized adherence to a structured surgical approach and performing high volume of cases may be contributing to low complication rates in our series. Just the last few words in terms of strengths of our study. This is the first study which calculates on reports on all 4 endometriosis staging system, and is the first study to also incorporate the venous classification system. We had in our center, we have a dedicated endometriosis specialist nurse who meticulously tracked all the patient's progress. She was the patient's first port of contact. So she was handling the database really well. And with that, we managed to track our patients well and make sure that nothing was missed, such as patients having wound infection following a laparoscopy. In terms of limitations, the limitation of our study includes lack of data on patient demographics. We don't have data on patients' BMI, previous surgery, height of nodule, and bowel function at baseline. And we know all of this can affect our data. And also that this was a retrospective data collection, which can lead to some risk of bias. But to mitigate this risk, we cross-check these information with multiple clinicians, including myself and Mr. Ghazali. And I think that's it from me, actually. Yeah.
Well, thank you very much, Avril. I think there is one question. If you have questions, guys, put it
I
in the
will stop
Q&A.
sharing now.
Yeah. So those patients with complications, any information on the quality of life after, we haven't been collecting long-term quality of life, unfortunately. So we haven't got an answer for you, Jamie, but the total number of those cases are, I think, 6 or 7. Is that right, Avril?
Sorry, what was your question? Say again.
The patients who had complications, the ones that had bowel complications in the end.
So when you say bowel complication, did you mean just fistula and leak?
Yeah. The fistula and
Yeah, so we had 4 patients in total. 2 was leak, 2 was fistula.
yeah. Okay. So, guys in the panel, do you have, although you know this study inside out anyway, your names appear on this study, but do you have any questions for Avril, like how could you be so wonderfully efficient in
Oh my
doing
God.
Avril, want to know your thoughts on class intra and LEJEndo as systems for tracking complications, because I know we've discussed a lot of the issues with them.
Yeah, and I think LEJEndo is a good way to track to classify the post-operative complications, because it essentially divides it into what kind of intervention they need, and how big the intervention it is can affect the patient at the end of the day. In terms of class intra, I didn't really agree with it because the definitions were quite vague. For example, needing minor treatment, like what does minor treatment mean? Or need, and then and one of it was when it says needing minor additional treatment, and I looked at the example that they provided was cautery of a bleeding vessel, which I kind of didn't really agree with it, but yeah.
So Milad is asking, what's the cutoff point to operate or keep the observation considering the complication risk? If the patient planned for ICSI, do we operate or do we do stimulation and avoid endometriomas during aspiration? Well, I think that's that really is a very difficult question to answer, because that needs a full discussion over how do we decide when to operate. You know, we follow the same surgical principle as every other specialty, that, you know, the surgery is the last resort if everything else has failed, and the first surgery is the best surgery. We then consider the complication rates, and this study was partly done because of that. We wanted to understand what complication rate is in my hands so that I can counsel my patients better. So let me show you, we only have 6 minutes. I don't think we can do the small papers. We'll leave them for the next session. But I have to share the Mars for you. Shall we put the poll on Flow for the data collection? So I'll share screen. Mars is a project that we've been working on for the last, what, 2 years? Well, a year and a half, really. And it basically is a, let me close this. You don't want to read my emails. Can you see my screen?
Yes, we can see it.
Yes, yeah.
Okay. So basically, it's a platform for collecting surgical data. This is my real data, but because it's anonymous, I can show you. So you have a dashboard that shows you the volume of your caseload, how many cases you've done. So this is from 2021 to January 25, how many of each operation you have done, what has been the Enzian complexity of your caseload, venous complexity, and route of procedure, and the complication rates, minor complications and major complication rates.
Ian, can you make it a bit bigger so everyone can see better?
Is it better?
Like, can you maximize your is Safari?
Okay.
Yeah, it's much better.
Okay. So yes, this is the volume. This is the each operation and how many of them have you done, and the complexity based on NZN, AAGL, route of procedure, and complications, minor and major. So just to quickly show you how it works, basically the idea is that we want to make everybody's life ridiculously easy. So let's say I've just done an operation and I want to say SK25 LEJEndo. And I want to now go and do my operation notes. So it adds the patient here, and then I go add, and you see we have NZN, venous, AAGL, and Kyle has come up with a really interesting algorithm that changes and converts these to each other, but we also use AI. So let me just say what I've done. We had a 6 centimeter endometrioma on the left and a 7 centimeter endometrioma on the right. The left fallopian tube was completely blocked and the right tube was patent. We had diaphragmatic endometriosis as well as adenomyosis. The left ureter was completely blocked by endometriosis and there was hydroureter. The left uterosacral ligament was normal. The right uterosacral ligament had a 1 centimeter nodule on it. There was superficial endometriosis all over the pelvis. So this then turns the voice into text, and actually the accuracy, I feel, is quite good. So this one didn't have a single mistake. And then we sent this, and if you notice, it does your NZN, venous, AAGL for you. It puts the, this one was not patent, this was one patent, and the venous exactly right. Even pelvic sideball, it understands because the ureter was blocked. It's a 4, the size of the endometriomas, everything, and the diaphragm. So it goes then to AAGL and then submit, and then basically you do the same with this. I don't want to take too much time, and then it creates your operation notes for you. So it just turns it into a really nice and clever, not clever, and clear operation note, and clever too. So if you are interested in testing it, and it's all free, at least for now, if you're interested in testing Mars and understanding what Mars is about, Flo has put the website to register as a beta tester. So please go there and register your interest. We have only until the 14th of January for that, 14th or 15th of January for that, because then we're going to close the beta testing and actually provide this to the public. So if you want to be a beta tester, please go and register there. We are working on a patient app, because the problem is the patient, when they come to the endometriosis surgeon, often there is not enough time during the consultation to go through all the what do you call it, symptoms. Let me show you this as well. And what we're doing is we're allowing the patients, again, using artificial intelligence, to send you their history beforehand. So when they come to see you in clinic, you have already seen this, and hopefully I'll be able to show you one of them. So symptom form that patient comes to you with. Can you see this? Can you see this?
Yeah, we can see it very.
Okay, so you see the pain scores, pre-op 6 months, 12 months, 24 months, the quality of life score, the bowel symptoms, bladder symptoms, and so on. All right, so if you are interested, please go and register. And I think we should close now. Sorry, Sarah Rizek, would you recommend doing retrospective reviews of this sort over a large time scale like 8 or more frequently over 2 to 3 years? Well, I guess depends on what you can do. It depends on the volume you do, and it depends on whether you think there's been a change in your practice over the course of those 2 years. What we wanted to do, first of all, was to capture all of my practice over the last 8 years. We had already published another paper showing the Tehran outcomes. So we decided to do it over 8 years, and Avril was keen to do a lot more work than 2 years or 3 years, but maybe our future studies will be actually easier using MARS, because all of that information is live now on our database and is always accurate to the day. Okay, so don't forget to join us on the 6th of February, same time, same place. I think it is going to be Flo. You're on mute.
All right, I'm just on mute. Yes, it is. We're looking at the HIFU for rectal endometriosis by Mr. Dubernard.
Yes. Okay. Yes. Gilles Dubernard is going to talk to us about HIFU, which is quite an interesting study. I met with him last month actually, and I'm really excited to hear what he is going to present to us. Thank you very much, everyone. Thanks for attending. Thanks for being with us as always. As I say, this is the 3rd year, and we're really expecting. And we were going to put a poll and ask you whether you like our new background, but well, we didn't do it. I hope you like our new background. Well, I didn't have a background, but
Next
anyway.
time we'll have the poll.
Okay, next time we'll have the poll.
Bye, everyone.
Bye,
Bye.
everybody.
Bye.
Thanks for coming.